So we'll be talking about stroke this afternoon, and I don't know, stroke is a big deal. If I talk about one of my probably my most feared complication of cardiovascular disease, stroke will probably top that list. And we've been seeing more and more stroke recently. So I think we'll first of all take a case presentation, and that's a patient we admitted maybe just over a month ago. He's a young man, actually, and one of the sad things about stroke in this part of the world is that we see younger patients with stroke compared to what they see in the Western world. I think it's because of our burden of hypertension. So there's this 39-year-old man that was brought in through the emergency department. He had a headache shortly after he lost consciousness. They said he vomited once, and then he had several fits before being brought to the hospital. It was said that he was not a known hypertensive, but he has never checked before. But as a presentation, his blood pressure was as high as 230/110. And the blood glucose on admission was also high at 256 milligrams per dl. Our presentation, he was unconscious, and his GCS was 4/15, which is as close to zero, as close to the ground as possible. He didn't have any sign of meningeal irritation then, and then on examination, he had both global hypotonia and hyporeflexia. What does this scenario suggest to you, sir?
Yes, thank you so much. This 39-year-old man has been brought to the emergency room with sudden onset symptomatology, symptom complex actually.
Move closer to the mic, sir.
Okay, so this young man rushed into the emergency room with a symptom complex characterized by sudden onset headache, loss of consciousness, and he was said to have vomited. From all indication, this patient likely has had a cerebrovascular event. Okay, and further analysis revealed that the blood pressure was found to be 230/110. That's a pretty high blood pressure.
Very high.
Okay, severely elevated blood pressure. And the blood sugar too was found to be elevated, and this patient was found to be comatose. Okay, so this patient, in all probability, has had a stroke.
So even before any serious test is done, one can actually really suspect that there's a stroke going on here.
Yes, yeah. on clinical ground, one wouldn't be wrong to suspect a stroke has occurred. Going by the WHO definition of stroke, sudden onset, focal or global neurological dysfunction of presumed vascular origin. So at this point, we presume it's of vascular origin. It fits into that definition in the sense that there is sudden onset of features pointing towards possibility of neurological dysfunction.
Okay, so the patient now had a CT scan done subsequently, and it showed the left thalamic bleed with some intraventricular extension, and the patient had quite marked hydrocephalus. We also took the liberty to do an ECG for the patient, which only showed an LVH with a strain pattern, and a diagnosis of acute hemorrhagic stroke was made with hydrocephalus. The patient with the background, or likely background hypertension and diabetes from the value that we have there. So, Dr. Kehinde, you are a stroke physician, and you briefly told us what a stroke is earlier. I would ask you that the imaging, is it consistent with the diagnosis of a stroke?
Yes, the finding, the CT scan finding in this patient, of course, with all evidence available, confirms this patient indeed has had a stroke. This is a 39-year-old individual. And mind you, the location of that bleed is in the thalamus. So this is one of the sites of predilection for hypertensive bleeds. Okay, so this patient didn't just have thalamic bleed. You will not be surprised that there is intraventricular extension. This probably is because of the close proximity of the thalamus to the third ventricle. So oftentimes, bleed involving the thalamus, the head of the caudate nucleus, you find that some of these patients may have seepages of blood into the ventricular system, which is the case here. Okay. And at that point, there was already evidence of hydrocephalus, meaning that the volume of bleed must have been significant.
Move closer to the mic, sir, so that people can hear you more clearly. So you define stroke using some of the WHO terms earlier. I would actually want you to actually tell us what a stroke is. So that, and then of course, I hear this term frequently that he had a partial stroke. Whether there's something called a partial or a full stroke. Can you tell us what a stroke is, sir?
Yeah, stroke is akin to brain attack. You know, the event that occurs following stroke, you know, describes an event that's comparable to what happens when individual suffers an heart attack. So stroke, in essence, is a brain attack. Okay, so when stroke happens, certain keywords define the feature. That's to be sudden in onset. There are times that where the onset, the progression of the symptomatology may be rather insidious. Okay, but it still comes back to the fact that it is sudden in onset. By that we mean within few minutes to few hours, and really maybe a few days. You know, stroke can evolve.
Okay, so is that suddenness that really defines it for us?
Yes, in that context, it's actually sudden, because there are other conditions that mimic stroke. Rarely will you have them, you know, setting in that manner.
Okay, so how common is stroke? Is stroke a common thing? Because I know that for heart attack, for example, in the past, the people used to say heart attack is not common in Nigeria, but now we know that it's not really true. At least not in Abuja. Yeah, exactly. Is stroke common or it's not common?
Oh, stroke is quite common.
Stroke is very common.
By far is the commonest neurological emergency. Okay, so patients come into the neurological emergency ward for various reasons. Stroke is the number one reason, and it is so all over the world. Okay, so stroke remains the commonest neurological emergency worldwide.
Is there a difference in the way stroke happens in Africa or Nigeria compared to the way they have it in, let's say, US or the UK?
Well, the presentation of stroke is essentially the same.
Okay.
Because the neurological system is virtually the same, whether among whites or black. Okay. However, accessibility to healthcare facility, level of awareness of the populace will go a long way to determine the manner and the mode
in which stroke presents. What of ischemic versus hemorrhagic, and then maybe the prevalence?
Yes, ischemic versus hemorrhagic stroke. There are subtle differences on clinical grounds. Before the advent of CT scan, before the advent
I need to clarify that question. What I'm saying is that ischemic and hemorrhagic, do we have the same proportion here compared to the Western world too?
Yes, the proportion is almost the same. Ischemic stroke still carries about
the larger weight.
80% of cases of stroke.
Okay.
And the distribution is the same, essentially, among white population compared to black population.
Okay, so we say that stroke is very common, and I would say that when I was down in the southwest, where I was working, we admitted maybe almost 3 strokes every night. Okay. And that's quite a lot. Yeah, so I agree with you entirely that stroke is very common, and I do agree that it's the commonest neurological emergency. But why is stroke this common? Why is the prevalence of stroke perhaps getting higher and higher? I mean, what are those risk factors that are driving this increase in burden of stroke that we have?
Yeah, risk factor for stroke, we talk about modifiable risk factors and non-modifiable risk factors. Modifiable risk factors are those ones that individuals have a lot to do in terms of prevention. Non-modifiable risk factors are those factors that individuals may have little or nothing they can do by way of preventing it. So among the modifiable risk factor, by and large, hypertension remains the biggest of them all. As a matter of fact, up to 80 to 90% of cases of stroke have one link or the other to poorly controlled blood pressure. Next to hypertension, we talk of conditions like diabetes mellitus, dyslipidemia, hyperlipidemia, heart conditions, certain lifestyles such as cigarette smoking, alcohol ingestion, and so on and so forth. Okay. For the non-modifiable risk factors, I mean, these are factors that individuals can do virtually nothing about. Age of the individual. As individuals grow older, risk of stroke increase. Next is sex. Generally, male sex is a high risk for stroke as compared to female sex. And of course, race, ethnicity. Race and ethnicity effect may not be a direct one as such. Generally, hypertension is commoner among blacks, and poor accessibility to health care further lend credence to the difference that race can play in risk of stroke. And there are also hereditary conditions. But these are not conditions that are common as such.
Okay. I think notably is the cardiac conditions you put up there, particularly atrial fibrillation, that we know that greatly increases the risk of stroke.
Exactly.
Which other cardiac conditions do we see that increases people's risk of stroke?
Yes, we are beginning to see increasing cases of people who suffer heart attack, myocardial infarction. So it's also rising on the list in this environment.
Wow.
Yes, valvular heart diseases generally also have a pivotal role to play in the etiology of stroke of cardiac origin. Individuals who have hypertension who don't necessarily have overt cardiac dysfunction. Something as simple as left ventricular hypertrophy carries weight, if not as much as these other factors.
Wow. That's interesting. That's actually a new one for me. So how does a stroke happen? I mean, blood is flowing quietly and normally through the brain. How does someone go from being an apparently normal person like me and you to developing a stroke? How does these processes happen in the brain?
Yes, like we said earlier on, stroke is a cerebrovascular event. What happens following stroke? There is usually a disease, that occurs affecting blood vessels. This can either be large blood vessels or small blood vessels. Among the large blood vessels, there are those ones that are within the cranium, intracranial vessels, and the extracranial vessels. And in addition, the problem that eventually leads to stroke could arise from areas even remote from the brain, such as the heart. Like we also highlighted earlier on. So when these processes that causes changes in these blood vessels occur in individual, maybe in the setting of high blood pressure, resulting into what we call atherosclerosis. There is laydown of lipids and other injurious substances in the inner lining of arteries, making those arteries to the lumen of the arteries narrow down. In other instances, it makes arteries friable. So that under such high level of blood pressure, such arteries can easily lose their integrity. Either they get blocked or they rupture. Yes.
What about this concept of penumbra and umbra that we've been talking about in medical school? Is it still relevant in talking about the pathogenesis of a stroke event?
Oh yes, it's still very much relevant. Following an insult, for instance, when there is occlusion of an artery, the portion of the brain that is at the innermost parts of the arterial territory, goes infected, and we call that umbra, meaning that there is complete cessation of blood flow. And when that happens, nutrients, oxygen will not be able to get to the affected part of the brain. And in addition, waste metabolites, there will be no way of getting waste metabolites out of those affected parts of the brain. So that forms the umbra. It's a place of programmed cell death. So the cell eventually are going to die, which is what we call apoptosis. Then you have surrounding the umbra penumbra. This is an ischemic area. Potentially it is salvageable. Yes, if necessary intervention are put into place, you are likely to reverse ischemic changes in this area.
Thank you very much for that. I think we should just take one of the polls now. We should take the next poll now to see if our audience are participating, and so let's gauge that. So the next poll should be poll, I'm not sure what that number is. Stop sharing, please, first of all, and then arrow down. Recognition. Okay, so here's the question here. The question reads that a 48-year-old man presented with waking up with weakness on the right side of the face over the last 24 hours. It was preceded by frontal headaches and malaise. There was no weakness in the arms or legs. Which of the following is true? So this is a 48-year-old man woke up with a weakness on the right side of the face, lasted over 24 hours. There was preceding frontal headache and malaise, but no weakness. Please, let's participate in the poll. Let's answer. It's maybe a little tough one, but let's try. The options are there. Try. No, it's a long one. The preserved ability of the to close both eyes tightly shut and wrinkle the forehead muscle is consistent with the diagnosis of a supratentorial stroke event. I know it's a fairly tough question, actually. The next option says that an associated dysarthria is more suggestive of a stroke than a new difficulty finding words. That's an aphasia. Then the next option says associated homonymous hemianopia is consistent with a lower motor neuron facial nerve palsy. And last option says all of the above. The people are fairly divided among the options. I thank God that Dr. Kehinde is there to tease out the question. I'm not set it, but yes.
Okay. Well, the pattern of distribution of the response.
Yeah.
Okay, the pattern of the distribution of the response is not unexpected, as you often find in clinical practice. Neurological disorders can be quite confusing.
Absolutely.
And so many conditions can actually look alike, but they are not exactly the same. So for this patient who, 48-year-old man, presented with, woke up with weakness of the right side of the face that lasted for 24 hours, and it was preceded by frontal headache and malaise. There was no weakness in the arms or legs. Which of the following is true? Okay, so the first option says the preserved ability to close both eyes tightly shut and wrinkle the forehead. Preserved ability to close both eyes tightly shut and wrinkle the forehead muscle is considered consistent with the diagnosis of a supratentorial stroke event. Okay, well, analyzing this, it's a possibility in the sense that this patient has hemifacial paralysis. One will expect that an upper motor neuron lesion, ability or function in the upper half of the face should be spared. Okay, so if this patient is able to has a preserved upper, face function, then in a way it is consistent with the case that was presented. But whether that is exactly what is going on or not is another case. Okay, so it is a possibility.
So it's probably true.
It's probably true. The next option says an associated new dysarthria, is more strongly suggestive of a stroke than a new difficulty finding words.
In this case.
In this case.
Which one is a stronger suggestive sign of a stroke?
Yes, depending. These are of localizing value actually.
Okay.
If a patient has difficulty finding word, most likely it is a cortical lesion.
Okay.
However, there are instances whereby a thalamic lesion too presents with difficulty finding words. Okay. Then coming to this.
So which one is more consistent with a stroke between in a patient that apparently has what could be a Bell's palsy and what could be a stroke? Which one is more consistent with, which one should push us more towards a stroke? Dysarthria or aphasia?
Difficulty finding words should actually. But in the event where patient has maybe brainstem stroke, for instance, and there is hypoglossal nerve affectation, such a patient can also have dysarthria.
Absolutely. Okay, what are the next options?
Reason why
imaging is necessary.
Yes.
Okay, the next option.
The next option says associated homonymous hemianopia is consistent with a lower motor neuron facial nerve palsy. That would be unexpected.
That would be wrong.
Yeah, that would be a wrong option.
So if we see this kind of patient and we can demonstrate that the patient has homonymous hemianopia, we should not call it a Bell's palsy, basically.
It's not a Bell's palsy.
Okay, all of the above.
Hemianopia will signify an upper motor
neuron lesion.
Okay, in this case.
Okay, so I think it's a fair attempt by the audience, and I think it just shows the kind of difficulty we have and the kind of things that should go through our mind when we examine a patient, whether we're going to label the patient a Bell's palsy or whether it's more likely to be a stroke.
Exactly.
Okay, so what are the clinical features of a stroke, particularly in relation to this? What ways a patient with a stroke will present?
Yeah, stroke is an emergency. And there is an acronym that readily comes to mind when dealing with a probable case of stroke. FAST is the word. F for facial weakness. Any individual who was otherwise previously healthy, developing a sudden new onset facial weakness should arouse our suspicion of a possibility of a stroke. The next there is A, which stands for weakness of arm or leg, again of sudden onset. Yes, any individual with known or no known cardiovascular risk factor developing sudden onset weakness of arm, that is upper limb or lower limb, it should arouse suspicion of possibility of a stroke. And then the third one is S, which stands for speech. Any episode of sudden onset speech impairment of any form, whether expressive in nature or receptive in nature, should arouse suspicion of possibility of a stroke. And of course, time is of essence. So we don't have all time to waste. Once any individual presents with any of these above symptoms, we should act fast.
So that's very interesting, and I will say that the vast majority of people with stroke will present with one of these three core things: facial weakness, weakness of the arm or leg, or speech impairment. What are the other key dominant, I'm not saying examination findings, but key dominant presentation of a stroke that we see sometimes?
Yes, the other presentation of stroke will now depend largely on the anatomical location.
But what are the very common ones so that we don't take so much time?
Yes, generally we talk of higher sensory loss. Okay, as in the case of stroke involving the parietal lobe. Okay, patient can come with what we call cortical blindness. In the case of stroke affecting the occipital lobe.
Absolutely.
And of course, stroke of the frontal lobe, in addition to the motor paralysis, will come with other behavioral problems, difficulty carrying out executive function, difficulty being able to understand what has happened in the anosognosia.
Absolutely. And sometimes we see those people with cerebellar and with brain stem stroke. What do they often present with?
Patients who have cerebellar stroke, for instance, will come with features of predominantly difficulty with coordination.
And gait imbalance as well.
Gait imbalance, ataxia, and all that.
Absolutely.
And of course, lost speech. Patients who have brain stem stroke, because of the peculiarity of that location, they often come with features of raised intracranial pressure very early during the
place is very tight.
The cause of stroke.
And of course, they can have all this what they call diplopia.
Yes, and of course, depending on the specific location of the brain.
There's a patient we had once. It was in his 50s, and what he noticed was that he was traveling, he just felt out of sorts in the car, and he had to park. And he realized that when he was coming out of the car, he wasn't weak in his legs, but he was just almost falling. Was falling towards the left. And he couldn't walk because of that, even though he could actually carry the leg, but was falling. And of course, by the time we did his imaging, he did actually have a cerebellar infarct. So many times people actually are not aware of those kind of presentations. I think we should go through the images and the case presentations you have for us today. Can we go to the first slide? Okay, before we go to the first slide, what are the common stroke mimics?
Yeah, there are certain conditions that look like stroke, but in actual sense, they are not stroke. And they can present a quite confusing clinical scenario. Yeah, the first on the list is condition known as transient ischemic attack. It's often an harbinger. It often could herald stroke. And if a diagnosis of transient ischemic attack is made, it's not enough to make the diagnosis. You shouldn't just make the diagnosis of TIA and send patient home. Potentially, it is a stroke. So such patients should be admitted, evaluated, and stabilized and observed for at least 24 to 48 hours in the hospital.
How do we define the TIA so that people just get that clearly?
Yes, TIA, transient ischemic attack. As the name implies, there is a transient cessation of blood flow to specific areas of the brain. But the compromise is not severe enough to cause a long-lasting neurological
deficit.
Okay, so there is a reperfusion. So the area of the brain that is affected gets reperfused, and the symptom typically lasts less than 24 hours. Majority of TIA will last less than 1 hour. Majority.
Absolutely. So if we have those patients that come with that kind of history, that this is okay, I had weakness of my hands and leg, but within 2 hours I was back to myself, we should not just send them home like that.
We shouldn't just send them. They should be admitted.
Absolutely.
The reason being that within first 24 hours, up to 7% of such cases eventually develop
a full-blown stroke. And I know a few stories like that, which were sad, preventable stories.
It can be really embarrassing.
What are the other stroke mimics you see that people thought it was a stroke, but alas, it wasn't?
Yes, the list is actually inexhaustive, but we have few cases listed there. Hypoglycemia should come to mind, because individuals who have hypoglycemia can develop sudden transient loss of consciousness, depending on the severity of the blood sugar, the level of the blood sugar, the blood sugar. Okay, some of these patients can develop permanent neurological dysfunction, a neuroglycopenia syndrome. Seizures comes into mind next, especially focal seizure. When individuals have focal seizures, subsequently after resolution of the seizure, they can develop what we call thought paralysis, and this can mimic stroke. Certain setting when individuals have brain tumors, especially elderly patients, they can have sudden bleed into the tumor. So they can come with a neurological symptom that is of sudden onset. Okay, these people can be mistaken as having stroke, but of course, careful history will be able to tease out the other surrounding
and imaging is still necessary.
Imaging is necessary.
Okay, so let's take some of your case presentation that includes imaging. So here you describe, I think I'll allow you to describe the case, sir.
Okay, this is a case of a 70-year-old man, right-handed, presented with sudden onset dysphasia, that's difficulty finding words, okay, and also noticed to have weakness on the right limbs and impaired comprehension. He couldn't understand spoken words when spoken to. He was diagnosed hypertensive earlier on and known to have dyslipidemia. He was, however, regular on medication. On examination, he was found to have global aphasia, right facial nerve palsy, and an hemiplegia with an hemisensory loss. Now, a CT scan was done for this patient. Looking at the
imaging,
the symptom of this patient, you will agree with me that most likely the stroke, this patient has had a stroke because the symptom is sudden onset, and the presentation is, is far-reaching. When you look at the area of the brain affected, so you won't be surprised looking at the imaging, the image of this patient. You can see the area marked with the yellow arrow, okay, an hypodense area, a well-shaped area of hypodensity is quite a large area.
Quite large.
So this patient has had a stroke in the middle cerebral artery territory.
Okay, so I can see that the impact is quite large.
Left middle cerebral artery.
And we can see quite some edema around that impact as well. I'll just ask you to just tell our listeners, how do you examine for this hemisensory loss? I know most people can identify facial nerve palsy, hemiplegia, and that, but how do we examine for hemisensory loss? Just briefly.
Yeah, here we are talking about cortical, sensory modality. It says cortical sensory loss. Here, the patient will have features such as atopographia. What that means is that when you put an object into the hand of a normal individual, you should be able to tell what it is.
What is the only, whether it's a viral or a photography?
Okay, so such patients will be unable to do that. Anosognosia, that is difficulty understanding what is wrong with the patient. So most patients that have had a stroke have difficulty appreciating the gravity of what has happened to them. So oftentimes you find patients who have had a stroke, maybe there is no one close by to take care of them, they remain at home. Okay, that's anosognosia. Patient cannot comprehend the extent
of severity of what's going
on. Of what is going on.
Okay, that's very, very interesting. Let's go to the next case, please. Okay, so here is a 60-year-old hypertensive for 10 years who developed sudden onset of inability to calculate and express his thoughts in writing. Wow. He was unable to follow road sign while driving, turned opposite side while traffic. So he started getting to the right and then going to the left. And then there's the imaging. What kind of case is this, sir?
Yes, again, this patient developed sudden deficits in his higher sensory function, characterized by difficulty calculating, difficulty expressing his thought in writing, and being unable to follow road sign. Putting this together, this patient has what you can describe as acalculia, agraphia, left-right disorientation, and finger agnosia. Okay, so this patient characteristically, looking at the imaging, the part of the brain affected, okay, is in the parietal lobe on the left hemisphere. Okay, so it's on the left hemisphere. That's a non-dominant hemisphere. Okay, so sorry, that's the dominant hemisphere. Sorry, dominant hemisphere. Okay, so you find such a patient having a syndrome known as Gerstmann syndrome. Okay. On the other hand, when this affects the non-dominant hemisphere, those one tends to have more of confusion.
Oh yeah. Oh yeah. Okay. Let's talk about the vascular territories in the brain. How do we describe the vascular territories in the brain? Skip. How do we describe the vascular territories in the brain? Because I think this is key for people to understand, link those things together.
Localizing where the stroke is, it is key to define vascular territories. The key thing to bear in mind is that the brain is largely supplied by two major arterial distribution, the anterior circulation and the posterior circulation.
Okay.
In the anterior circulation, you have three major vessels.
Okay.
You have the anterior cerebral artery, the middle cerebral artery, and the posterior cerebral arteries.
Okay.
All these are branches of the internal carotid artery, and they constitute the anterior circulation.
Okay,
in the brain. Then you have the posterior circulation. These are mainly branches of arteries that rose from the vertebral artery.
That's the posterior circulation is mainly from the vertebral.
Mainly from the
vertebral artery.
So the posterior circulation largely supply the brainstem and the cerebellum. While the anterior circulation supply the hemispheres. And you have this network of anastomosis, network of connection between the anterior circulation and posterior circulation. And this is known as the circle of Willis. The importance of this is that in the event there is an insult or there is an event that results into blockage of an artery in the anterior circulation, there can be a reperfusion from the other part of the circulation. So from this picture we have here, you notice that largely the hemispheric proportion, the largest proportion of the hemisphere is supplied by the middle cerebral artery.
And it's the commonest culprit we see.
Yes, which is by far the largest of the branches of the internal carotid artery. So generally we talk of the lateral surface of the hemisphere.
What's the role of the homunculus in helping us to localize a stroke?
Yes, the homunculus, the motor cortex and the sensory cortex. The motor cortex is located in the pre-central area. And you have the sensory cortex in the post-central area. And you have the homunculus version for the motor cortex and the sensory cortex. So this cortex, the motor cortex, actually extends somewhere from the inferior aspect of the lateral surface of the brain. Along the pre-central area.
I think it's difficult to talk about this actually without the pictures. I think we'll leave that part. Now, so I think many of the pictures you gave us, many of the case scenarios you gave us earlier are ischemic stroke. So talking about hemorrhagic stroke, number one, does it follow the vascular territories? And just use this case to discuss that, sir.
Yeah, it's a bit different scenario when talking about hemorrhagic stroke. Because number one, the choice of arteries that are affected in hemorrhagic stroke. You rarely have large arteries. As in the case of God is so kind. You rarely have large arteries involved in hemorrhagic stroke. In case of hemorrhagic stroke, what we often have are the small perforating arteries. You can imagine if middle cerebral artery should decide to rupture, it will leave no room for intervention.
You're right.
Okay, so hemorrhagic stroke generally affect those tiny perforating arteries.
But they still cause very big problems for us.
Indeed, they still cause, but it is such that they allow sufficient time for you to be able to reasonably
do something. Okay, so this patient in this case scenario that is there, a 40-year-old man who was said to have presented with a sudden onset headache, some vomiting, and weakness of the right limbs. He has been hypertensive for 5 years. Unfortunately, has not been using the drug. And as presentation, the BP was very high at 190/110, and there was weakness. There was weakness on one side. So what can you tell us about that CT scan, sir?
Yes, the CT scan in this 40-year-old man is showing a lesion located at the where the yellow cursor is, the yellow arrow. That happens to be the left hemisphere of this patient. If you look at it very well, you see an area of relative whiteness comparable to
the rest of the brain.
Yes, to the bony plates. Now, number one. Then number two, the shape of that lesion is oval in shape. Okay, so these are two features suggesting that this patient has had a bleed. Okay, the location of that bleed is deeply, situated within the hemisphere. Okay, that is where you have the basal ganglia and the thalamus. Okay, so in this case, it's looking like a putaminal bleed.
Okay, but so in this kind of case now, should this, if the patient, let's say this patient did not have a CT scan, if someone gave him aspirin very early, would it have maybe helped, or I don't know, the situation? Let's say he has not done the brain imaging and someone said, okay, stroke, aspirin.
Yeah, it can be challenging, especially practicing in sub-Saharan Africa, where you may not have ready access to neuroimaging, distinguishing between hemorrhagic and ischemic stroke at the spur of the moment. But what I will advise is WHO criteria is not completely useless, even though it has its limitations. Okay, so for this kind of a patient, it's a 40-year-old man. Epidemiologically, typically, hemorrhagic stroke tends to be commoner, in younger individuals, and especially those who are below 6th decade of life. For great majority of those who are in the 7th decade, in all probability, they will likely have ischemic stroke. So that's the first step in this patient. And the second step is that this patient develops sudden onset headache, vomiting. Headache is a very strong predictor of an hemorrhagic bleed. However, there are circumstances under which patients with ischemic stroke can also have headache. If the infarct is really very large, they can have headache.
Okay, looking at the location of this bleed, what are the common locations for hemorrhagic stroke?
Yes, we talk of site of predilection for bleed. And from the picture here, we can see these are the places where you have those tiny perforating arteries. By far, the commonest site still remains the basal ganglia. Basal ganglia. We talk of putamen, we talk of globus pallidus, we talk of thalamus, caudate nucleus. So in that order. Then of course we can involve the pons and the cerebellum
as well.
Then rarely you can have even what we call lobar hemorrhages. Lobar hemorrhages. Lobar hemorrhages, the mechanism of bleed in them is different from the one for the hypertensive bleed. It often occurs among elderly patients who have developed some kind of degeneration. We call it amyloid degeneration. So lobar hemorrhage.
So apart from bleeding into the brain parenchyma, I know that patients can also bleed into the subarachnoid space. Is it the same mechanism that leads to this, or how does this happen? This is a case. Use this case to explain that.
The commonest form of hemorrhagic stroke remains intracerebral hemorrhage. However, patient can also bleed in locations other than within the substance of the brain. And subarachnoid hemorrhage comes next to that. So in subarachnoid hemorrhage, hypertension could be a risk factor, but it is not top on the list. Maybe in order of frequency, it will probably be number 4 or 5 on the list. So you have condition topmost on the list, circular aneurysm, ruptured berry aneurysm remains the commonest cause. Then you can have fibroelastic degeneration, certain individuals who have fibroelastic degeneration, and certain conditions like mycotic aneurysm.
Absolutely.
Okay, then you now talk of other collagen disorder.
Okay, and I know that patients with ADPKD, that's autosomal dominant polycystic kidney disease, are prone to having those kind of aneurysms.
Exactly.
So this case scenario of this 60-year-old man with sudden onset headache, vomiting, and loss of consciousness, whose GCS was 4 at presentation, and he had neck stiffness. I think when we see that loss of consciousness with neck stiffness, we tend to think of subarachnoid hemorrhage, meningitis, then possibly SICH with intraventricular extension.
Exactly.
So this person has discerebrate posturing and bilateral extensor plantar response. Can you explain the findings on that CT to our audience, please?
Yes, this cranial CT scan is looking so unfriendly in the sense that you can actually see presence of hyperdense lesion in some unfriendly location. You look at the perisylvian fissure, okay? The perisylvian fissure. Yes, perisylvian fissure.
Okay.
Yes, they are filled with blood. And also looking at the posterior horn of the right lateral ventricle is almost completely filled with blood.
That's the whitish thing we're seeing there.
Whitish thing.
And we have a bit on the left too, on one of the slides. I think they cut on the right lower aspect of the field.
Exactly. Then we also have, the perimesencephalic region.
I'm aware that for patients who have subarachnoid hemorrhage, sometimes if a CT scan is done early, it may not pick the blood. What can you also comment about this?
Usefulness of CT scan in picking subarachnoid hemorrhage. CT scan is very, very sensitive actually.
Okay.
But the problem most of the time is that if the time it takes for the blood to circulate, if the CT scan is done pretty late, you may not be able to
see the blood again.
Okay, but generally CT scan done within 48 to 72 hours. Okay, generally within 1 week. Okay, beyond 1 week, you may not be able to see
the blood. Okay, so if a patient presenting with what looks like a stroke now, how should we approach this patient? Maybe in a few, because we are short of time now, what are the key investigations we should do for this patient, and how should we manage the patient before we get in imaging and then after we have the imaging? What are the key investigations first of all?
Okay, well, in investigating a patient with CT scan, with a stroke, CT scan is, neuroimaging generally is very important. Okay, so where facilities are available, we should not hesitate to get an urgent neuroimaging, especially CT scan is much more readily available and is faster to conduct. Okay. So urgent non-contrast cranial CT scan should be arranged as soon as possible.
What about the patients that maybe don't have so much money and they want to save their money for treatment and say they don't want to do the brain scan or they don't think it's very important?
It can be really very difficult, but maybe in the hand of experienced physician, neurologist, may be able to offer some help. I have managed patients who are unable to perform CT scan and were able to apply WHO criteria with all its limitations, and we manage successfully. But of course, that's not what is recommended. The recommendation is for us to get a cranial CT scan at least.
Okay, what other investigations are key in this patient?
Yeah, we're interested in the random blood sugar, urgent random blood sugar of the patient. Because patient following stroke is a stressful event. You can develop stress-induced hyperglycemia. Some of these patients will have diabetes that we are not even aware of. We want to check the kidney function. The same reason why the high blood pressure has affected the brain could have also affected the kidney
as well. And the electrolytes can also affect the stroke outcomes.
Stroke outcome. Want to check the lipid profile. Want to do the liver function test, especially a patient that has had a bleed. There could just be
some coagulation problems. And I'm happy that on this slide here you have the carotid Doppler, which many times we forget to do for patients.
Exactly.
Okay, so how should a patient with stroke be managed? What are the key things in the management of stroke?
Yes, acute management of stroke is very important. How a patient who has suffered a stroke is managed within the first few hours will go a long way to determine the outcome of such a patient. So generally,
we have less than 5 minutes more for the discussion part. Yeah.
Want to admit the patient in the emergency ward.
Okay.
Want to resuscitate the patient.
Okay.
Resuscitation, you want to ensure that the airways are patent. You want to ensure patient is breathing, respiration pattern normal, patient saturating well. If patient is having abnormal respiratory pattern and it's not saturating well and it's comatose, that would be an indication to transfer to ICU without waste of time.
If the patient is in a high caliber center like Cardiocare or somewhere like that, what kind of intervention can be done acutely? Let's say a patient presented within the first hour or so of presentation. What acute interventions is available for a patient who is having an acute stroke?
Yeah, the intervention that really comes to mind is thrombolytics. But the way it is in the country today, very few centers, that is if there is any at all,
absolutely
administer thrombolytics.
Because the setup needed to do that is immense.
Exactly.
We have to do neuroimaging within how many minutes of the stroke?
The challenge starts from timing the stroke accurately. Absolutely. For instance, a patient went to bed healthy, woke up with a stroke. At what point do you say such a patient had a stroke? Unfortunately. So it is presumed that the time the patient was last seen well,
which is the night before.
So that has already ruled out such a patient.
How many hours do we have to do thrombolysis?
Yes, we talk of window period. Generally, 3 to 4.5 hours, generally speaking. Okay, so the outcome is best when done within this
time period
interval. Yes.
I'm hoping that within the next few years, we are able to be doing more thrombolysis and perhaps this mechanical thrombectomy, hopefully in Nigeria as well. So, of course, you've mentioned a bit on the resuscitation of a patient with stroke, but talking about fluid therapy, what do we do in terms of fluid in stroke?
Yes, in terms of fluid, it's another area that we should get it right from the word go. Okay, never should we get carried away. The fluid that is recommended for a patient that has had a stroke is normal saline. Normal saline is safe and you can never be wrong if you start normal saline in a patient with stroke. Of course, you want to monitor the blood sugar of such a patient. Rarely will you have patients who have had a stroke coming in with hypoglycemia. Okay, it can occur.
That's okay.
So, but it's not a commonplace thing. We should avoid isotonic fluid at all costs, especially hypotonic fluid. Hypotonic.
Yeah.
Sorry, the word should be hypotonic. That's a typographical error. Dextrose water should never be given under any circumstance. This can increase the risk of cerebral.
Some doctors are afraid of, they say, because the blood pressure is already high, they don't want to give saline. What's your comment?
It's one of the myths that people throw about in stroke management. There are various reasons why blood pressure can be that high. Okay, but in that patient whose blood pressure is high, it is needed to maintain cerebral perfusion pressure. Okay. And the normal saline, the essence of giving normal saline is to improve perfusion.
Absolutely.
Of the affected part of the brain.
Okay, let's take another poll before we complete the rest of the presentation. I think we'll take the last poll there, yes, evaluation management of the stroke, so that our audience is stimulated for this part. So the questionnaire reads that a 65-year-old man was rushed to the hospital with a sudden onset loss of consciousness. He was sitting with his friends watching a soccer match when this happened. Our presentation, his GCS was 10/15, and the blood pressure was 170/95 millimeters of mercury. Which of the following is correct? Please, let's participate in the poll. 65-year-old, sudden loss of consciousness while he was watching a soccer match. I'm not sure whether it's Arsenal that was playing. GCS was 10/15. BP was 170/95. You have 4 options for what's the 4, 5, 1, 2, 3, 4. There's 5 options. So what's this is most unlikely to be a stroke? That's not likely to be a stroke. Forgive my English. In the absence of clear lateralizing signs, brain imaging is unnecessary. Aspirin should be given immediately via nasogastric tube in the patient. Blood pressure medications should not be administered. Body temperature does not affect stroke outcome. So these are quite a few options. I think we can stop it in 10 seconds time. We'll try to finish before 6:30. We apologize for taking this much time. Okay, so these are the poll outcomes. Dr. Kehinde, what comments do you have on this?
Okay, the pattern of distribution of the responses. The first one, this is most unlikely to be a stroke. Well, I think that statement is actually wrong. Okay, this patient in all probability has had a stroke.
Absolutely.
Okay, the next one says in the absence of clear lateralizing signs, brain imaging is unnecessary. Again, it would be wrong to assume that in the absence of lateralizing sign, brain imaging is unnecessary, depending on the location of the stroke.
Absolutely.
Okay, the patient may not necessarily have what we call lateralizing sign. Okay. The third option says aspiration should be started immediately via nasogastric tube in this patient. We should tread with caution in this 65-year-old man. Remember, this patient is in the 7th decade. Even though he had a sudden onset event, going by epidemiology, it may likely be an ischemic stroke, but you never can be too sure because looking at the other symptomatology, suddenness of onset, loss of consciousness at the onset, and of course the blood pressure of
170 over 95.
Not neither here nor there. Okay, so but it's likely this patient has had the bleed. Okay, so we need a neuroimaging.
Absolutely. What of blood pressure medications in this kind of scenario with the limited information?
Yes, blood pressure medication should not. Yes, of course, that would be perfectly correct. At the instance patient comes in, the first thing to do is not to rush to start antihypertensive. Whichever way you look at it, whether it's an ischemic stroke or an hemorrhagic stroke, despite the fact that we've not been able to get a neuroimaging done.
Okay. So talking about infections in stroke, infections are common in stroke. And sometimes patients have infections, they have high temperature. Number one, should we do anything about the temperature and how should we handle infections in stroke briefly?
Yes, at every point in time and at all costs, fever should be treated, whether you know the cause, the source or not. Because if fever is allowed to linger for long in stroke, studies have shown that it is associated with worse.
Well, we still have a lot of place to cover. So we know that infections are very common in stroke. In your experience, which infections would you say is the most common in stroke?
Well, by far the commonest source of infection within first 72 hours remains from aspiration pneumonitis.
Okay, so aspiration and respiratory tract infection is especially common in stroke, and we should address that very aggressively. What's your take on feeding patients with stroke? Should a patient with stroke be fed, and how soon should a patient with stroke be fed?
Yes, as part of the initial evaluation of stroke patient, there should be a formal objective assessment of ability to swallow.
Okay.
For patients who are conscious and with an intact ability to swallow, they should be encouraged to feed.
Okay.
For patients who are conscious with impaired ability to swallow, consideration should be given whether to pass NG tube immediately or to delay. This will be determined by quite a number of factors. Okay. Then so for patients who are unconscious, of course, care should be taken in passing NG tube hurriedly.
Oh yeah.
Yes, especially in the first few.
So what patients should we suspect that swallowing may be compromised? What should we see that we suspect, and then we go ahead to do a formal swallow test for the patient?
Yes, 1 out of every stroke patient will come in with impaired swallowing, and we should always have this at the back of our mind.
Okay.
And the risk factors for that will include things like brainstem stroke.
Oh yeah.
Patients who have suffered a brainstem stroke invariably will come
with impaired swallowing.
Patient who is presenting with repeat stroke, either second or third stroke, probability of a bilateral corticobulbar
What are clinical features? Lesion. What clinical features should we see and we suspect that this patient may have a swallowing issue, apart from the patient reporting that I have swallowing problems?
You see such patients drooling saliva.
Okay, so drooling of saliva.
Yes, you see such patients with nasal quality speech.
Absolutely.
You see such patients coming with dysphasia. Most patients with dysphasia, aphasia, absolutely, you should look for.
Or very marked facial weakness as well. Sometimes they have difficulty in masticating very well. Now, so the big one, we've talked a lot about blood pressure, and I won't want us to really do all of that. But briefly, what would be your comment on blood pressure handling in stroke, apart from the things we've mentioned when we're talking about the hypertensive crisis?
Yes, blood pressure management in acute stroke is one of the most important, line of management, because if we get it wrong, then we are likely to worsen the patient's condition. Generally speaking, when the patient has had an ischemic stroke, the first rule is to do no harm.
Okay.
Yes, we should never be under such a pressure to start antihypertensive. By principle, you are not expected to touch that blood pressure within the first 10 days, except, if the patient has any of the following condition. If the BP is persistently elevated above 220, 120, or mark of 145, you don't want to allow such a patient for long, because that can cause untoward effect. If there is not evidence of ongoing target organ dysfunction, or organ damage,
like encephalopathy,
myocardial infarction,
which are not so terribly
eclampsia, so on and so forth. However, we should always do all that is possible to exclude the patient is not in pain, patient is not retaining urine. A patient that has retained urine will be under duress, so reflex the blood pressure can go up.
So is this the same for both ischemic and hemorrhagic stroke, or is it different from hemorrhagic?
For hemorrhagic stroke, the target is a bit different because you don't want to wait the blood pressure get to 220 over 120. As a matter of fact, by the time the blood pressure exceeds 180 over 110 persistently, risk of hematoma expansion is very...
And the ICP way, the interperial pressure gets higher and higher.
Exactly. But to what extent you want to lower the blood pressure, there are two schools of thoughts to this. There are those who believe in intensive treatment. You should rapidly and aggressively lower below 140. And there are those who are on the conservative side. Just maintain the BP between 140 to 170.
And in the tricky balance, if you really reduce the BP, you control the hematoma, but there's a risk of more and more ischemia.
Yes, ischemic conversion. So rapidly lower the blood.
What of anticoagulation in acute stroke? Some people feel if it's ischemic stroke, we mentioned aspirin earlier, which is fine, but are there other things that should be done in terms of antiplatelets and anticoagulation?
Well, this is another dicey area that we have to exercise a lot of caution. Yes, but generally we should do risk profiling of our patient. What is the risk of this patient developing a thromboembolic phenomenon? So patients that come in with heart failure, patients that have chronic hypertension, patients who are older than 75, patients who have diabetes, and patients who may have previous stroke. This patient merits anticoagulation. However, it has to be weighed based on individual patients.
Absolutely.
For instance, a patient that has a stroke more than 2/3 of anterior circulation, we shouldn't be in a hurry to start anticoagulation. These are the ones that hazard the risk of hemorrhagic conversion,
which can cause a whole quagmire problem on its own. Thank you, Dr. Kehinde, for this time. I'm sorry I will not be able to allow us to continue so much beyond this because of time that has gone, and I want us to be able to take the questions and concerns that people have regarding this presentation. So I hope our people listening have typed the question in the chat box, and we'll try to keep the time to a very short period now so that we don't keep people waiting. So there's a question here asking about the role of vitamin E and antioxidants in managing stroke. What's your take on that, Dr. Kehinde?
Yes, antioxidants generally been shown to have presumed benefits in the setting of acute ischemic stroke. Because of the cascade of events that occurs following ischemic stroke. There is generation of free radicals. So free radical scavengers have been shown to prevent progression. Free radical scavengers have been shown to prevent progression of expansion of the umbra, to take more of penumbra. So this borders on activities of free radicals.
So they basically help to, at least to some extent.
Exactly. But in prescribing vitamin E, generally we want to give a much more potent preparation, which is the tocotrienol. Yes, it's 40 times actually more potent than the regular
vitamin E.
Tocopherol.
So tocotrienol, you call that. That's so nice.
Tocopherol.
So someone is asking here, how do we differentiate, perhaps clinically or otherwise, between hypertensive encephalopathy and a stroke? What's your take on that, sir?
Yeah, that's a very important question, because oftentimes you find patients Hypertensive encephalopathy is one of the stroke mimics that we didn't mention. Okay, and there are times that you can confuse the two. But the way to go about it, history is very important. For hypertensive encephalopathy, it occurs in the setting of patients who are previously not known to be hypertensive. Okay, so they typically come with symptom of headache, which drags for like 5 days before other neurological symptoms set in. Confusion, convulsion, subsequent loss of consciousness. Stroke, on the other hand, is sudden in onset. Okay, even if at the level of history you are unable to distinguish between the two, neuroimaging is important. But there are times that even a stroke patient can come, with normal CT scan, depending on the time.
That's true. That's okay. True. And patients with hypertensive encephalopathy, typically they don't have focal neurological signs like that. Okay,
so management-wise, if still at that level you are not sure, rather than rush to give an antihypertensive, which is the right thing to do for hypertensive encephalopathy, start monitor.
Absolutely, or discuss with the stroke physician.
Exactly.
So I think that's beautiful. And someone asked for the role of mannitol in the management of stroke.
Yeah, for ischemic stroke and even for hemorrhagic stroke, because of the cerebral edema. Okay, cerebral edema will cause a raised intracranial pressure. So mannitol is an osmotic agent which is able to draw out the excess fluid, thereby reducing the.
So when there's raised ICP, either clinically or imaging determined, we should consider the use of mannitol for use of stroke. So someone is asking about the same mannitol again now. What's the role in patients with raised ICP with dexamethasone as well as furosemide? What's your comment on those three agents?
Dexamethasone has no role in
stroke.
Raised ICP
from stroke.
We talk of the mechanism of cerebral edema. Okay. So the mechanism of cerebral edema in ischemic stroke is cytotoxic. Okay. For those conditions originating from vasogenic origin, then dexamethasone we find
it. Things related to tumors. Absolutely. So there's a question here which I'll answer, that in a patient with stroke, how do we control the blood sugar? Let's say blood glucose is very low, and you said that we should use saline. So in this patient, number one is that you can add 50% dextrose to the IV fluid. That's one. And we should also remember that dextrose saline, that's talking about 5% dextrose saline, is actually dextrose in normal saline. So that can actually also be used. But to be on the safe side, it's better inside your normal saline, you give some bolus of 50% dextrose water, so that can be used to correct the hypoglycemia. Okay, but that's quite a different situation. Yes, please.
Before we go on, depending on the level of the hypoglycemia.
You wrote 3 milligrams per day.
3 millimole. Okay, but if patient is coming in with such a very low level, okay, you should give 50% dextrose water. The volume you are giving at that point
is not an issue.
Cause much in terms of time.
And the hypoglycemia has a very high priority at that time.
Exactly.
Obviously. Someone asked how important are diuretics in the management of a stroke patient. Mannitol that you mentioned and furosemide, which is also used, actually osmotic diuretics, and they have a role in the management of cerebral edema or raised ICP in stroke context. In addition to that, we also know that at the stage where the blood pressure is to be controlled, after 10 days, like you said, we have quite a number of blood pressure medications we can use, and diuretics are part of them as well, right?
Exactly. Okay. But care should be taken in not over-diuresing patient that has had an acute stroke.
So not to cause hypovolemia, which should worsen perfusion problems.
Exactly.
When do we use thrombolytics and antihypertensives in stroke? Briefly.
Thrombolytics. Well, for patients who merit the criteria for thrombolysis, a setting where you have facility and patient presenting within 3 to 4.5 hours. Okay. If such a patient comes in with blood pressure in excess of 180/110, one of the contraindications is severely elevated blood pressure. So you have to acutely lower that blood pressure.
I will want to add to what you are saying, that the setting in which those kind of thrombolysis treatment can be offered has to be where there are facilities for such things, because thrombolytics is okay. So for example, here in Cardiocare, we do quite some thrombolytics, sometimes for myocardial infarction. We've done a few for pulmonary embolism here in Cardiocare, and of course, you need an HDU setting, probably somewhere where you can get a continuous blood pressure monitoring. Even in some cases, you have to consider interarterial blood pressure monitoring. But the criteria for thrombolysis in stroke is quite strict. It's quite strict. Even to get neuroimaging done in that short time, it can be a challenge.
CT scan within 45 minutes.
Absolutely. So you have to be somewhere where all those kind of necessary gadgets are found at a point in time. I would also try to answer the question that is related to myocardial infarction and stroke. Of course, patients who have myocardial infarction are actually prone to having stroke. And myocardial infarction actually has to be recognized on time. So that patients can have the kind of care they need to reduce the chances of clot forming in their hearts and then having this kind of cardioembolic stroke. Of course, the treatment that is offered for myocardial infarction still remains, the gold standard still remains percutaneous coronary intervention, that's PCI, which we offer here in Cardiocare. And in those kind of situations, a angiography is done that looks at the arteries of the heart and identify which artery is blocked and such arteries are opened up. If that is done early, the dyskinesis or hypokinesia we mentioned that happens in a particular part of the heart and with clots that can form there, arrhythmias as abnormal heart rhythms, the chance of all of those are less, and the chance of the person having a stroke is much more reduced as well. So I think cardiovascular issues are actually quite interlinked. But I'm happy that we've enlightened and discussed rub mind with our audience this afternoon, talking about stroke. Thank you, Dr. Kehinde, consultant neurologist, for coming here. We apologize to our audience. We took quite a bit of your time today, and sorry for a bit the late start. I think we started about almost 10 minutes late. We'll try to start early tomorrow. The cause of the slight late start today was actually we're waiting for people to get up to maybe perhaps 100. We log in earlier tomorrow. We'll log in earlier tomorrow, and we had Cardiocare opening today. I need to mention that. I didn't mention that for us. I wish we took us on a tour for that. We had the Honorable Minister of Health himself here today, and quite a number of other dignitaries in Abuja. That's why most of us are wearing red tie, and I'm sure you saw Dr. Alekan earlier wearing a red tie as well. We did a tour of our cath lab. We had quite a number of procedures going on, up to 8. Dr. Iseko actually has not been here, just into the room now because of the part of the procedures. So thank you very much, everybody, for being a part of this. We want to take cardiovascular medicine to a higher level in Nigeria, and I know that we'll get there. I know families, patients that have died of cardiovascular issues, and some of these could have been either prevented or at least in their once. One step at a time. So thank you all for joining this evening's session. 4 o'clock tomorrow, we'll be here again, and we plan to start on time tomorrow. Tomorrow's session is going to be quite juicy. We're going to be talking about the part of it all, myocardial infarction, and how this is handled and what's possible in Nigeria and what is not. What else? A couple of years ago, one of our professors of nephrology actually had a myocardial infarction, and he had to travel out for some things. Things are changing now. Let's talk about that tomorrow. So we'll be expecting everybody here tomorrow, and we're going to have a great session. Thank you once again for joining us, and thank you, Dr. Kehinde, as well.
Thank you once again.
All right.